Hello and welcome. Today we are going to talk about adaptive optics and clinical applications of integrated wavefront aberrometry. I'm Dr. Thomas Wong, Associate Clinical Professor at the SUNY College of Optometry. What is a wavefront refraction? This is often a misnomer. There's a lot of fear amongst eye care providers that wavefront refractions and other new technologies will replace optometrists. But the important thing is the future of eye care and the future of quality optometry will rely on each optometrist and eye care provider being able to use new technologies like wavefront aberrometry to better serve our patients. A wavefront refraction is an integrated measurement of the optical pathway with wavefront analysis. Most of us are familiar with the Hubble telescope, which has been used to take high-definition images and videos of stars light years away. The same technology is used to study and measure the refractive error, structures, and physiology of the optical pathway in providing better care to our patients, including better refractions and spectacle and contact lens prescriptions and analysis for refractive surgery. Who should have a wavefront refraction? Who should have this type of advanced clinical outcome support? In my opinion, this needs to be studied further, but I feel more comfortable and better seeing any patients from the age of about 12 on using wavefront analysis. Let's look at my future image of the future eye exam, utilizing new technologies like advanced clinical outcome support. It starts with cura personalis optometry. Cura personalis is a medical term that refers to care of the entire person. The eye in a person is not just a number, the eye is not just a camera, but it's attached to a human being with families and feelings. So we need to understand that each patient is an individual, and we need to care for each patient with empathy and compassion. The basis of each exam and each doctor-patient relationship begins with that relationship and that trust that we build with our patients. It starts on the left with biomedical informatics, getting information from previous exams, doctors, the health information exchange, so that we understand the health and the status of each patient before we see them and care for them. Imaging, including high-definition images like wavefront aberrometry, OCTs, MRIs, also move down to ultrasound and other older technologies. And it all begins with communication. We need to communicate with each patient, their families, communities, and other members of the healthcare team to provide quality care to our patients. On the right, we move to integrated testing, especially with new technologies like wavefront analysis. We don't go from one test to two tests. Often we go out of order, providing the proper care and testing for each patient. This all involves patient education and outcomes. In spite of the quality care that we've always given patients, wavefront technology allows us to get better data to better care for our patients. And it also gives us the responsibility of educating our patients as to this new technology. These concepts are complex, not only for other optometrists and other clinicians, but especially for patients. So we need to spend more time providing empathetic care to our patients. This all involves clinical outcome support for each patient. Let's look at ways of measuring diopters for patients. Wavefront aberrations are something that involves the difference between an ideal and actual result. The difference is often measured in both microns and/or diopters. Aberrations can be measured at both the pupil plane and further back in the retinal plane to give us a better idea of how these images are shaped and how the aberrations are different for glasses, prescriptions, contact lenses, and refractive surgery. Often higher order aberrations can affect how a patient sees, even if they're seeing 20/20. So it allows us to take better care of our patients who, despite good visual acuity, are having problems with their vision or their visual comfort. The eye's optical integrity is something we need to really think about and discuss as we look at wavefront refractions and analyses going forward. Adaptive optics and the study of this science really will allow us to provide better refractions and care for our patients. The eye as an optical instrument. We all look at the model of how the light shines into the eye, through the cornea, through the pupil, through the optical pathway. But we know the eye is not a camera. The eye is attached to a human being, and it's not just a camera. The retinal image is not the endpoint of each refraction, as with a camera. However, we do know that a better analysis of the optical pathway is vital in understanding how to refract, provide proper prescriptions for patients, and manage them over time, longitudinally. It will give us a better objective data for better refractions and improved patient management in the long run. Patients may do very well with their glasses or contact lens prescriptions for years, but when they develop problems due to cataracts, dry eye, other aging changes, or other functional changes as they go through life, better data and better subjective refractions are key to the management of each patient. If we look at the optical pathway, it starts with the tear film. Through the cornea, that clear avascular layer that allows light to shine through the eye and refract, through the aqueous humor, through the pupillary diaphragm of the iris that allows light of the correct angular aperture to meet the internal needs of the visual system. It goes through each eye's crystalline lens, through the vitreous humor to focus on the retina. There are two angles that we need to consider when looking at high technology like wavefront refractions that are integrated to the care of patients. Angle kappa is the angle between the pupillary and visual axis. It can often be important in strabismus patients. If you're measuring a wavefront refraction or doing integrated wavefront aberrometry on a patient, if they're not looking at the right place or they have strabismus and eye turn, that will affect the reading you have, and it's something you must interpret and understand to better care for patients. Angle alpha, which may be more critical when looking at myopia control or other types of things that we consider now, looking at this global change in myopia, this big shift in the way myopia has risen, especially not only in Asian countries, but throughout the world. That angle alpha is the difference between the center of the limbus and the visual axis. Let's look at a few maps, but today let's look at this one instantaneous map. It represents the actual geometry of the cornea. It calculates the radii of localized areas along the meridians. It's also referred to commonly as the tangential map. It shows local irregularities such as ectasias like keratoconus or pellucid marginal degeneration, edema, swelling in the cornea, or scars from previous injury or infections. To use a simple example, we often use the example of a basketball, whereas one type of map may look at the basketball globally, an instantaneous or tangential map may look at each dimple very specifically to give us a better idea of the mapping of that particular cornea and eye. Let's look at this slide, which is the visual representation of these visual axes, specifically angle kappa and angle alpha. You can look at the colors here. In the top, the red, and then the blue, and then the green, showing the difference between the photopic or the visual angle during bright light conditions, the mesopic or more dark adapted measurements, and angle alpha, which, as I mentioned, goes out to the limbus of the eye, which is often very important in myopia control, where peripheral refractive error, not just central, is very key to myopia control and management of these patients. Let's look at one specific patient that I saw a few years ago. This patient was a very intelligent, athletic, 15-year-old African-American female. She had been followed by us for many years, had seen many optometrists and ophthalmologists in New York City and elsewhere. She wore her glasses but was unhappy with her vision. The uncorrected distance visual acuity was about 2100, in the right eye and the left eye. Best corrected distance visual acuity with glasses and contact lenses was 20/40 minus in both the right and the left eye. If we look at this integrated wavefront aberrometry, let's look in the center at the placido disc image. You notice that the mires are clear and regular, so dryness or irregularities in the ocular surface were not an issue. If you look at some of the smaller numbers that are very difficult to see here, the angle kappa was very small and normal, so the patient was fixating properly, looking at the right portion of the device, so we got good measurements. Now if you look at the left, you'll see the red areas very much in the center. The top slides are all the right eye, and the bottom slides you'll see with the L are the left eye. In the center, they're almost mirror images that represent the very large dioptric refractive difference between the central few millimeters and the mid-periphery and the periphery. You often don't see this, so this is a very unusual condition. The symmetry shows that this is not an artifact, but it's something symmetrical, it's something that this patient was born with. Now, why does this patient have such a high refractive error in the center and it evens out very closely? If we look to the right at some of the other higher order aberrations, spherical aberration, coma, and trefoil, we see that it varies from the center to the periphery. Now, what is this? When we looked at the images of the eye, medical imaging, we knew that it wasn't a cataract. If we look here in the bottom center and the bottom right, we see images that represent spherical aberration, very classical. If we look at the center axial map, the anterior corneal topography, we see that is relatively normal. If we look to the far right, we see that very pellucid-like, crab claw-like image in the upper right that represents a very specific central irregularity in the internal part of the eye, which in this adaptive optic model refers to the area from the posterior cornea through the posterior vitreous. If we look to the far left, the optical pathway difference for this eye represents the refractive error throughout the entire optical pathway, from the tear film to the retinal plane. So this patient needed something very different. If we look at the image here on the left eye, we see in the center that the corneal surface and the ocular surface is very normal. If we look to the far right, we see the internal optics, which I mentioned go from the posterior cornea to the posterior vitreous. It's very irregular in the center, showing that classic spherical aberration model in the bottom right. And we look to the far left, which shows a mirror image of the right eye, where the optics in the center, the refractive error is very different than the periphery. This patient, after medical imaging and much testing, was shown to have lenticonus, which is a cone-shaped lens due to bulging from a thin lens capsule. It can be anterior or posterior. Anterior lenticonus usually occurs in males, is bilateral. Associations include Alport syndrome, which is an autosomal dominant basement membrane disease associated with acute hemorrhagic nephropathy, deafness, anterior polar or cortical cataracts, and albipunctatus-like fundus spots. This patient actually had, during imaging with slit lamp photography, showed many anterior polar and cortical cataracts, which were very specific in this patient. Posterior lenticonus, which is what this patient had, is much more common. Slight female predilection is shown in the data and research, and it may have associated cortical lens opacities, which this patient had. So how do we provide for this patient? Someone who had such a large difference between the center and the mid-periphery was not able to have glasses and allow them to see well. They certainly were not able to have a contact lens that had such a large refractive difference between the center and the mid-periphery. So this patient was a patient that was seen and needed cataract extraction, needed surgery to improve the patient's vision. And this is often very common in lenticonus patients. So this is one example, and this last patient shows that integrated wavefront aberrometry and adaptive optics really is a very efficient and accurate way of diagnosing patients and allowing them not to run through the gamut of really this type of diagnostic dilemma, and allowing optometrists to be much more focused and precise in their diagnosis and co-management with ophthalmologists, where this patient needed cataract surgery and glasses and contacts really didn't help. I want to thank you for this opportunity to discuss adaptive optics, integrated wavefront optometry, and other new technologies that really provide a more precise way of taking care for our patients in our communities. It is often very difficult to deal with diagnostic dilemmas, referring patients, and patients really during this COVID-19 pandemic really don't want to spend a lot of time running back and forth from office to office. Anytime we can use technology to provide better care for our patients, including more time-efficient care, is really welcomed by our patients and communities. But as we spoke about ethics and professionalism earlier, it's all about providing the proper care, empathetic care for our patients. I really appreciate this opportunity to speak to you, and I want to thank you.